Good afternoon, or good evening, or good morning, depending on when and from where you're joining us. I'm Dr. John Iskander, Scientific Director of Public Health Grand Rounds, and it's my pleasure to welcome you to our November 2019 session. Public Health Grand Rounds continuing education is available for physicians, nurses, pharmacists, veterinarians, health educators, and others. The course code is PHGR10. That's one of our most frequently asked questions. PHGR10. Please see our website or the CDC Continuing Education website for more details. And here is our continuing education disclosure statement for this session. Grand Rounds is available on the web and all of your favorite social media sites. Please send questions to grandrounds@cdc.gov, and we'll try to include your question during our Q&A part of today's session. Want to know more? We have a featured video segment on YouTube and our website called Beyond the Data, which is posted after the session. This month's segment features my interview with Dr. Rachel Rogers from CDC ATSDR. We've also partnered with the CDC Public Health Library to feature scientific articles about this session. The full listing is available at cdc.gov/scienceclips. In addition to our outstanding speakers, I'd like to acknowledge the important contributions of all of the individuals listed here. Thank you all very much. Here's a preview of upcoming Grand Rounds topics. Please join us live or on the web at your convenience. And it's now my pleasure to introduce the Director of CDC's National Center for Environmental Health and the Agency for Toxic Substances and Disease Registry, Dr. Pat Bryce.
Thank you, John. So today we're going to talk about per and polyfluoroalkyl substances, better known as PFAS. PFAS, a large group of compounds used in consumer products and for specialty applications like fighting fires, have been found to be persistent in the environment and in our bodies. This is not a new issue to CDC. Our flagship public health surveillance system, the National Health and Nutrition Examination Survey, first detected PFAS in human blood samples over 20 years ago. We're still learning about the extent to which PFAS contamination from drinking water and other sources across the country is affecting people's health. Much of the science around the harmful effects of PFAS exposure is still emerging. We'll hear about that today. CDC and ATSDR are working closely with communities affected by PFAS contamination to help them understand the extent of the contamination, the impact of the exposures. CDC is a science-based, data-driven organization, but we also understand that we serve people and communities where we live, work, pray, and play. These impacted communities are more than our partners in research. They represent fellow citizens who deserve our empathy and our best efforts to address the knowledge that they can bring to bear to address their problems. In this Ground Rounds, you'll hear directly from people who are living in affected states and communities, and you'll be inspired by their leadership and the actions they've taken to address public health. You'll also learn what we know about PFAS, the science, and what the key gaps in the knowledge are. So with that, I welcome you all to the PFAS Ground Rounds, and let's get started.
Thank you very much, Dr. Bryce. Our first speaker is Dr. Rachel Rogers.
Hello, and thank you for joining us today for our discussion about PFAS. We're going to be talking about what PFAS are, what we know about them, what we need to learn about them, as well as how the public health community is responding to increasing concern about exposures to these compounds. I'm going to be giving a fairly broad introduction to the subject with more in-depth presentations to follow. I'll start with a bit of background to define and generally describe PFAS. I'll explain how PFAS have been used in the past and how exposures to PFAS have occurred. I'll summarize some of the findings of some important early investigations, and I'll provide some highlights of the ongoing multi-agency public health response. PFAS make up a large class of more than 5,000 individual chemicals. Chemicals in the class are characterized by a carbon chain that's either partially or fully fluorinated. So where there would be hydrogen atoms, instead you have fluorine atoms. The carbon-fluorine bond is one of the strongest in organic chemistry, and as a result, PFAS have many unique properties. They repel both water and oil, and they're particularly well suited for use as dispersants and surfactants, as well as in certain types of firefighting foams and some consumer products. PFAS are also remarkably persistent in the environment and in people's bodies. Once PFAS are released into the environment, they don't break down or degrade, and when people are exposed to them, they tend to stick around, bound to proteins and circulating through the body. Ingestion is the primary PFAS exposure pathway. PFAS can be found near areas where they're manufactured or where products containing PFAS have been used. In these areas, PFAS are found in the drinking water, in fish from contaminated surface water bodies, in soil, and even in dust. PFAS exposure can also occur through the use of certain consumer products, things like stain resistance treatments for fabric and carpets, some food packaging materials. There's also growing evidence that some food products that are grown or raised in areas with PFAS contamination may also contain PFAS. We also know that fetuses and babies can be exposed during pregnancy and through breastfeeding if the mother was previously exposed. PFAS development and use in the United States has a long and important history. PFAS were first synthesized in the 1930s and 1940s, and by the 1950s, large-scale production of PFAS was well underway. In 1968, a few very early studies reported PFAS detections in human blood samples. Manufacturing peaked between 1970 and 2000, and somewhere in that time frame, preliminary toxicity studies began to suggest that PFAS may have the potential to cause adverse health effects in rats and mice. Samples collected by the CDC's National Health and Nutrition Examination Survey, also known as NHANES, in 1999 revealed that more than 98% of people tested had some PFAS in their blood, suggesting that exposure to these chemicals was widespread. One of the initial investigations of PFAS exposure in the United States was drinking water sampling conducted in accordance with the EPA's third unregulated contaminant monitoring rule, also known as the UCMR3. This program required that all public water systems serving more than 10,000 people, as well as 800 smaller water systems, monitor for 30 contaminants, including 6 PFAS, between 2013 and 2015. Of the 4,600 systems that were sampled, 65 had detections of 2 species, PFOA and PFOS, that exceeded the EPA's non-regulatory drinking water health advisory. However, many systems were not tested. So this is some of that data. Of the approximately 51,000 community water systems in the United States, 4,600 were sampled. Of those, 129 systems had any detections of PFAS, and 65 systems had detections above the EPA health advisory. So that represents about 6 million people. But it's important to note here that the public water systems that were not tested serve about 60 million people, not to mention the 33 to 38 million people who get their water from private wells. So while this initial exposure investigation really opened our eyes to the extent of the exposure problem, it was by no means a comprehensive picture. Another important initial investigation was the measurement of PFAS in samples collected by NHANES. Since 1999, NHANES has measured PFAS in the blood of the US population. This work has revealed that most people in the United States have PFAS in their blood, especially PFOS and PFOA. This work has also shed light on exposure trends in the US population. Since 2002, production and use of PFOS and PFOA in the United States has declined. As the use of some PFAS has declined, some PFAS blood levels have gone down as well. So this is that data. You can see that from 1999 to 2014, blood PFOS levels declined by more than 80%, while blood PFOA levels declined by more than 60%. Two other species, PFHXS and PFNA, show less of a change over time. This could be due to greater persistence in the body and thus a slower response to changes in production and use, or other factors that we're still trying to understand. The C8 Health Project was another important early investigation. This large epidemiological study gathered information on over 60,000 people living in a community near the DuPont Washington Works facility in West Virginia, a population that was found to have high levels of PFAS in their drinking water. So here you can see the facility and the surrounding area. The facility was positioned right next to the Ohio River, and the releases of PFAS since the 1950s impacted individuals across many counties and several different water districts in the Mid-Ohio River Valley. Settlement of a lawsuit against DuPont resulted in improved water filtration in the impacted water districts, the establishment of the C8 Science Panel, which was charged with assessing the links between PFOA exposure and a number of different diseases, as well as the C8 Health Project, which provides medical monitoring for those diseases determined by the panel to have a probable link with exposure to PFOA. So the science panel was an independent panel of 3 scientists that was chosen to assess the links between PFOA exposure and a number of diseases, and resulted in numerous publications that really laid the foundation for what we now know about the relationship between PFAS exposure and the potential for adverse health effects. The team reported on what were called probable links between exposure and health outcomes, but it's important to note here that a probable link is a legally defined term, not a scientific one. So these were health conditions for which a connection to PFOA exposure was determined to be more likely than not. The panel found probable links between PFOA exposure and 6 health outcomes: high cholesterol, ulcerative colitis, thyroid disease, testicular cancer, kidney cancer, and pregnancy-induced hypertension. In addition to these initial investigations, the federal response to concerns about PFAS exposure really began to accelerate in 2015 and 2016, when ATSDR released an updated draft toxicological profile for PFAS, and EPA issued a non-regulatory drinking water health advisory for PFOA and PFOS of 70 parts per trillion, either individually or combined. In 2017, ATSDR added 4 PFAS to the substance priorities list, and many agencies across the federal sphere are now working to provide direction and to answer questions about PFAS exposure, human health effects, cleanup, and public health action. ATSDR in particular has conducted investigations, public health assessments, or supported site work conducted by partners in more than 40 communities across the country, some of which you can see here on this map. We also recently received funding to conduct PFAS exposure assessments and a multi-site health study to better understand the extent to which people are exposed to PFAS through drinking water and what those exposures may mean for human health. So before I hand it over to Dr. Ducketman, it is worth noting some of the significant challenges that PFAS pose for impacted communities, as well as for public health researchers. There is a lot of concern about PFAS exposure, but it is still growing as new communities are identified and new pathways of exposure are uncovered. Only a small handful of PFAS have been studied well, and new species are being developed to replace others that are being phased out. We need more research on the health effects of these compounds and better analytical methodology to detect and measure human exposure. We know that when people are exposed to PFAS, it's rarely to just 1 or 2 species. Scientists are still studying what the health effects of exposure to mixtures of PFAS may be. This is a big gap in our understanding. We also need better methods to treat PFAS-contaminated drinking water. Some existing technologies can remove PFAS from water, but they are expensive, they are difficult to monitor and maintain, they may not remove all PFAS, and they introduce the new problem of how to responsibly dispose of the concentrated PFAS that collects on the filtration media. There is still so much that we don't know about PFAS exposure and the potential for adverse health effects. Questions about how best to help people who have been exposed and how to prevent future exposures are keeping the scientific community quite busy. So now I'll thank you for your attention, and I'll turn it over to Dr. Ducketman, who will expand on some of what we know about the human health effects of PFAS exposure. Thank you.
Thank you, Dr. Rogers. This talk is about the human health effects. And, I should also thank our wonderful host from CDC for creating this educational opportunity. This talk is about the human health effects. And because there are now more than 2,000 publications about them, some information will be on the PowerPoints for which there will not be time to have any extended discussion in this abbreviated conference. The scope of the C8 Health Project was very large. Dr. Paul Brooks, whose picture you saw earlier, enrolled more than 60,000 people in medical monitoring in 2 states along the banks of the Ohio River. And we began to learn about PFAS in some detail from that project. Dr. Rogers has already mentioned a couple of the outcomes, elevated cholesterol, pregnancy-induced hypertension. There were others that were noted but were not denoted as probable links: liver function abnormalities, elevated uric acid related to exposure. And it was very interesting for the cholesterol findings to find this dose response, where a lot of the action is at the lower end, unfortunately, of the exposure. There's a couple of different dose response models for that in pharmacology that might explain that, but we don't actually know why it's like that at this point with certainty. And in some ways, it becomes a mistake to focus on that one very large first study, because since then, multiple other studies have looked at similar outcomes and other outcomes in many other populations around the world. For example, there are now more than 15 studies showing links to cholesterol, more than 5 showing links to abnormal higher liver functions and uric acid, and 3 different populations, to my knowledge, that pregnancy-induced hypertension has been, or some aspect of pregnancy-induced blood pressure problems has been denoted. In addition, other studies completely have addressed, including studies from Harvard, the relationship between exposure to the 2 most common PFAS and diminished response to vaccines and other aspects of immune downregulation, which at this point is one of the most certain outcomes of health exposure, and also obviously one of general public health concern. In addition to that, Dr. Rogers has mentioned reproductive outcomes such as the inevitability of transplacental transport and transport by breastfeeding to newborns, so that most infants and young children have higher PFAS serum concentrations than their mothers. And in addition, there are now a number of findings about decreased duration of breastfeeding in those exposed, and that's an interesting finding for which there may be several different types of explanation. And then there's developing research about other aspects of health concern, such as reproductive and developmental aspects and congenital defects. Endocrine disruption is a very difficult area in which to do research, and there's lots of research going on about thyroid disruption and steroid hormone disruption, including androgens and estrogens relating to these compounds. Communities are naturally concerned about cancer. Dr. Rogers has mentioned that the C8 Science Panel linked these to several urogenital cancers, seminoma and renal cell There's other concerns about prostate, liver, and bladder cancer. And that's not a complete list, of course. And then other health outcomes of research interest are mentioned here, of which really active areas include obesity in those who are exposed in pregnancy and early childhood, bone and joint health, and microvascular kidney disease and immune-mediated outcomes. What we're the most certain about lipid abnormalities and liver function changes and thyroid hormone changes and immune changes may not be what communities are the most concerned about, the reproductive hazards and the cancer questions, which are harder to do research on. So in response to those difficulties, what should happen in affected communities? Obviously, the first rule of public health in this instance is reduce the exposure. And when the exposure is from water, that means that alternate sources or treatment of water is the recommended outcome for those who have contaminated water. Then the second priority is reduce the impact of past exposures, which leads in turn to questions about medical monitoring, which is defined as case finding in order to refer individuals for further evaluation and needed treatment, which can include testing for biological effects and assessment of exposure either by models or for the PFAS, because they're easy to find in blood, actual measures. That is to say, the long-acting ones are easy to find in blood. The short-acting ones are darned hard. CDC has provided for more than 2 decades really excellent basic guidelines about when medical monitoring is helpful. And the bottom line for that is there should be a reasonable evidence of exposure. There should be evidence that exposure leads to adverse outcomes. And then following that, there should be some way of thinking about monitoring and whether it brings a net benefit, including earlier detection or and other things such as the ability to intervene. There are lots of advantages to community level monitoring as opposed to individual monitoring. Access to testing is facilitated. It's less expensive. There's a summary report back function to the community that's not possible at the individual level. There are obviously economies of scale and its ability to do quality improvement. And we know that communities appreciate the activity from the C8 Health Project, which has already been mentioned, and from other types of medical monitoring projects that have been done in the past, and some of which are still ongoing. But an important limitation of these medical monitoring projects is finding the resources to do them. There are enormous difficulties to getting the resources to doing community level medical monitoring, so then individuals want to know what can they do for themselves. Well, my personal physician's perspective is that the CDC ATSDR criteria that were published more than 20 years ago also provide reasonable guidance to people and their clinical providers, so long as the exposure is documented and any approach taken between the individual and their clinician is simple, acceptable in the community, and the provider and the individual agree that this is about net benefit. So things that are simple, that clinicians understand, are simple measures like body mass index, home blood pressure monitoring for pregnant women, which might augment the normal things that physicians do, and a discussion about fertility and reproductive concerns, which is one of the most frequent phone calls I get. In terms of laboratory testing, lipid panels, liver function tests, TSH, especially during pregnancy, because there's a lot of evidence about thyroid hormone being more important to the developing human. Uric acid and creatinine and urinalysis are all tests that clinicians understand very well and are not hard to get. PFAS testing, on the other hand, is darn hard to get, and the barriers should be stated honestly. It takes a committed clinician-patient relationship in order to get PFAS testing done, and it will be expensive if done on an individual basis. On the other hand, when we communicate the limitations, it's very important to be honest and open that we are not saying that it should not be done necessarily. Patients and community members may not agree that they're better off without testing. They have lots of scientific reasons to feel that way. So in summary, Some health effects of PFAS exposure are well documented. Others are the subject of ongoing investigation. And unfortunately, our knowledge is based on only a few of the many possible PFAS contaminants that can be in water and that will be in water in the future. Reduction of exposure and reducing the effects of past exposure are overarching principles of the public health response, and medical monitoring according to established public health guidance is beneficial to populations in exposed communities and can reasonably inform choices for individuals who don't have access to community-level testing. I'm now going to introduce Steve Sliver, who's from the Michigan Department of Environmental Protection.
All right, thank you, Alan, and thank you, CDC, for the opportunity to be on this fine panel here today. To give you Michigan's perspective, talk a little bit about how we are addressing PFAS contamination. All right. So, you've heard about how pervasive and persistent PFAS can be. This diagram illustrates how PFAS are cycling throughout our ecosystem because we are not sequestering or destroying them. Look at the landfill where all of the consumer products and industrial waste disposed there release PFAS into the leachate. That leachate goes to a wastewater treatment plant not designed to treat them. So they pass through to surface water, impacting drinking water and fish. And some of those PFAS can accumulate in the wastewater treatment sludges, which could be land applied on agricultural lands and affect the soils, groundwater, surface water runoff, and maybe even the crops. And so our challenge is to really understand what the occurrence of PFAS are throughout this cycle and how to break it to protect public health. So PFAS emerged in Michigan when we found really high concentrations in fish tissue near the former Wurtsmith Air Force Base in Oscoda, high enough to warrant a don't eat the fish advisory. And then we looked in surface water around there and found over 5,000 parts per trillion of PFOS compared to about 2.5 parts per trillion statewide in some of our other surveys. Then a few years later, our Army National Guard told us that they had found PFAS contamination at the Camp Grayling training area. Shortly thereafter, while we were investigating some former disposal areas in North Kent County for a manufacturer of shoes that use Scotchgard, we found alarmingly high levels of PFAS in private residential wells. And so this statewide scope and potential public health threat of PFAS contamination led to the creation of Michigan's PFAS Action Response Team, or MPART. And MPART is an advisory body made up of 7 key state departments responsible for environmental and natural resources protection, agriculture, public health, military installations, and fire departments, as well as commercial airports. It leads the coordination of all of our efforts across the state to help ensure that we've got an effective and efficient approach. It's also responsible to coordinate with local and federal partners and other stakeholders to ensure that we're sharing information and leveraging our resources, because no one can do this alone. And MPART really is the reason Michigan has been so successful at rapidly addressing PFAS contamination using a data-driven and science-based approach. So we have over 70 sites in Michigan where groundwater contamination exceeds our state cleanup criteria of 70 parts per trillion PFOA, PFOS. These are landfills, industrial sites, military installations, and airports. And we've got a lot of sites, and some people would say Michigan is more contaminated than any other state in the country. Not true. We are just looking more rapidly and comprehensively than anyone else in the country. We're looking at over 100 more today of thousands of potential sites, and we prioritize those investigations based upon whether or not an impact to groundwater could migrate off-site and impact someone's drinking water. Protecting public health is job one. And when we do identify a site, we have a coordinated public health response, including all of the MPART agencies and local health and municipal officials, to inform the residents possibly investigate private wells, as well as sometimes in the interim, before we fully understand or characterize offsite migration, put them on a presumptive remedy of filters and bottled water. We have integrated PFAS testing into the surface water survey and surveys of fish as well. And this helps us identify discharges of PFAS into our surface waters so we can eliminate them. We've also found really high concentrations of PFAS in foams that are generated on impacted surface water bodies. In addition, we've worked with our wastewater treatment plants, asked them to look upstream to industrial users, for example, like chrome platers, to identify them and eliminate those discharges into the headworks of the wastewater treatment plant before they get passed through onto surface water. And the results of some of those surveys actually can also lead to public health recommendations. Those results for fish can lead to don't eat the fish, consumption advisories. The foam, over hundreds of thousands of parts per trillion of PFOS have been found in these foams. That's led to, at a minimum, stay out of the foam, rinse it off if you get it on you. And some of the surface water results, for example, up near Oscoda, the Wurtsmith Air Force Base, led to testing of deer and don't eat the deer advisory. So we're fortunate in Michigan. We've got some standards that can lead the investigations and cleanup of PFAS. Our groundwater cleanup criteria are protective of drinking water. That's at 70 parts per trillion, PFOA, PFOS, lifetime health advisory. If that groundwater also vents to surface water, it has to meet a more stringent standard for PFOS, 12 parts per trillion. Our surface water quality standard is 12 for PFOS because it accumulates in fish and we eat the fish. Now, if that surface water also is a drinking water source, the standard drops to 11. Now, when it comes to drinking water, we've been relying upon EPA's lifetime health advisory recommendations. It's really all kind of voluntary, and the state's been leading the way on doing all the testing. But to understand what's in our drinking water and whether or not we need standards, we, in 2018, sampled all of the community water supplies and larger non-community supplies like schools and daycares on their own wells. And this past year, we've gone back to some of them and sampled some more to get a better understanding of any seasonal fluctuations perhaps that we might be seeing, as well as what might be happening in surface water supplies where fluctuations could be more dramatic. We've also added some non-transient supplies that, for some of our more vulnerable populations. Overall, good news. 97% of the supplies that we tested in 2018 don't require any follow-up at this time because of no or very low concentrations of PFAS found there. And we tested for 14 of them under the EPA method 537. We did find 2 supplies that required an immediate response, and they had alternate water provided immediately, and there's continuing follow-up occurring there. Found 3% of those supplies, or about 61, where the levels weren't at that 70 part per trillion threshold, but they do require ongoing monitoring, again, to determine whether or not those levels change, as well as looking in the community to see what's the source of that. And if they do have to provide alternate water, what are their options? Is it hooking up to a neighbor, digging a deeper well, or adding treatment? So Michigan has found PFAS in our drinking water supply, and we know from what our scientists are telling us that 70 parts per trillion is probably not low enough for PFOA and PFOS, and we're probably not focused on enough of the contaminants out there. And so typically what we do when we want to integrate testing into our municipal water supplies and have them take that over, including the cleanup or mitigation of it, we adopt federal standards, federal MCLs, maximum contaminant levels. Well, EPA's action plan does not call for those to be adopted anytime in the near future, and so we feel compelled to act now given what we know about our state's water supply. And so our governor earlier this year asked MPART to create a science advisory work group to provide some health-based values to help inform a rulemaking process for state drinking water standards. And they did that. They completed their work at the end of June, and they came up with these 7 health-based values for PFAS in drinking water. Now notice the values vary anywhere from 6 to 400,000, and it's for 7, not 2, compared to the EPA Lifetime Health Advisory of 70 for PFOA and PFOS. These values have been adopted by MPART and passed on to the Department of Environment, Great Lakes, and Energy, and are now the basis for the rulemaking, which is well underway. If these do become enforceable MCLs in Michigan, remember those 62 supplies I talked about, probably about 24 of those will have to provide some sort of treatment or alternate water to their consumers. So again, Michigan has got a comprehensive approach to providing, to addressing PFAS contamination, and we've been successful because it's been multi-agency and working with our stakeholders as well to have that data-driven, science-based approach. So, thanks for your attention, and I'll now invite Andrea Amico to come and, yep.
Hello. Hello, I am here today to share the community perspective on PFAS contamination. My goals today are to tell you about how PFAS contamination has impacted my community, how we organize to respond, the nature of community concerns and needs, and the important role of community-level engagement and actions to protect public health. I know public health is a routine phrase to this audience, but it's important to remember the public in public health includes real communities and real families. I live in Portsmouth, New Hampshire. It is home to a large business park called the Pease International Tradeport. The Tradeport was developed in 1991 and is currently home to about 250 many different types of businesses that employs about 10,000 people a day. It is a significant economic hub for the seacoast area of New Hampshire, and it attracts a diverse group of people to its location each day at the 2 large daycare centers, colleges, restaurants, golf course, medical office buildings, and more. Prior to the development of the Pease Tradeport in 1991, this location was a large and active Air Force base for about 35 years. The site has a significant history of environmental contamination. In 1991, Pease was classified as a Superfund site, and since that time, there has been extensive investigation, monitoring, and remediation to clean up the toxic chemicals and pollutants there. In May of 2014, high levels of PFAS were discovered in the drinking water wells at the Pease Tradeport, causing the largest well to be shut down immediately. The source of the contamination was identified as aqueous film-forming foam, or AFFF, in use when Pease was an active Air Force base. AFFF polluting water supplies is not unique to Pease, as it is the only firefighting foam that met the specifications for all branches of the DoD in putting out petroleum-based fires for decades. Pease was one of the first communities in the nation to discover our PFAS in our drinking water, but we are not alone. Many communities across the nation from coast to coast have been affected by PFAS in their water. This map from the Environmental Working Group shows hundreds of other sites with known PFAS contamination, and the numbers continue to grow. It's important to note AFFF is not the only source. The chemical companies that manufacture PFAS have also released these chemicals into water supplies surrounding their factories and their industrial sites for years. This is clearly a widespread issue in our nation's drinking water. Just because communities have only recently discovered PFAS in their drinking water, the reality is that the contamination has been there for decades, and the exposure has been ongoing for a long time. PFAS at Pease has affected me personally because my children attended daycare full-time on the Pease Tradeport, and my husband worked there for 9 years. My family drank water from those contaminated wells. When I first learned of the contamination, I had no idea what these chemicals were, but I was determined to understand the effects this exposure would have on my family. Myself and 2 other moms pictured here, Elena Davis and Michelle Dalton, all had children exposed at the daycare on Pease. Together, we formed a community action group called Testing for Pease. We initially were focused on advocating for a PFAS blood testing program to better quantify our community's exposure, but our advocacy has expanded beyond just blood testing, and we are now national leaders and advocates on many areas pertaining to PFAS, like health studies, more protective standards in drinking water, medical monitoring, and more. We have been incredibly successful in organizing our community and strongly advocating to local, state, and federal government officials. The Pease community was offered a PFAS blood testing program that started in 2015. Many of those samples processed here by the CDC lab. The results of our PFAS blood test showed significantly elevated PFAS blood levels when compared to the general population. We have also been fortunate that the Air Force has taken action to clean up the contamination in the environment and groundwater and have installed filtration on the drinking water wells. Our ongoing advocacy has led us to work with ATSDR to develop a PFAS health study at Pease that recently started this fall. And our PFAS health study will serve as the model for 7 other PFAS communities across the nation. However, the action we have seen at Pease is not typical. Many communities have received very little action around their PFAS contamination. Pease was one of the first communities to discover PFAS, and we organized quickly and effectively. However, as more communities discover the problem and the large scale of this issue becomes more understood, communities see less action and responsibility taken for their contamination. This is not okay. My work as a PFAS community leader has opened the doors for many opportunities for me to share my story, engage with high-level officials to raise awareness, and to advocate for action for all impacted communities. Last year, I had a one-on-one meeting with then EPA Administrator Scott Pruitt to share the community perspective. I testified at the first ever hearing in the Senate on PFAS last fall in DC. Earlier this year, I attended the President's State of the Union address as Senator Shaheen's guest to raise awareness of PFAS. And in September, I gave a TEDx talk on my story as a community leader. Prior to learning of my family's exposure, I was never an advocate or an environmentalist. It took this very personal issue to awaken the community leader inside of me. And I'm not doing this work alone. I just want to recognize there actually are some members from impacted communities here today in the audience. The photos in my slides are faces of real community members across the country that have been impacted by PFAS contamination and have come together to push for action and answers for their communities. In June 2017, the National PFAS Contamination Coalition formed. We are a group of community leaders from across the US and Guam, representing 13 states and 21 communities. The coalition allows us to collaborate together, share best practices and lessons learned, and work in a unified way at a national level to bring about the action and answers we all need. Our coalition works to testify at government hearings on PFAS, present at national conferences, participate in exposure assessments and health studies, and actively engage with many levels of government, academics, scientists, non-governmental organizations, and other sectors all working to address PFAS. We work tirelessly to be seen, to be heard, and to make sure our perspective and needs are at the forefront in addressing this widespread public health issue. As impacted communities facing a significant environmental exposure and with unclear answers on what this means for our health, we grapple with many challenges and concerns. PFAS is a large class of over 5,000 chemicals that are ubiquitous in our environment. They are in our consumer products, our food, in wildlife, and in our drinking water, in some places at very high levels. However, PFAS has been presumed safe until proven toxic, which means communities are allowed to be exposed to many different PFAS without knowing the full extent of the consequences on our health. Based on what we know about some of the 5,000 PFAS, communities feel PFAS should be seen as toxic until proven safe and regulated strictly and conservatively to protect public health. Currently, there are no enforceable legal standards for PFAS in drinking water at the national level, and only health advisories for 2 PFAS out of 5,000. These are forever chemicals that do not break down, build up in our blood, and impact multiple tissues and systems of the human body. PFAS are passed to babies through the placenta and breast milk and have been shown to impact fertility. We must act now in the best interest of human health and stop the exposure with strict regulations as a class. Another challenge we face is accessing PFAS blood tests, interpreting these results, and consulting with our physicians to know what to do next if we've been exposed to PFAS. Unfortunately, most physicians are not extensively trained in environmental health and not prepared to counsel patients on how to get their blood tested and how to monitor their health when they have suffered a significant PFAS exposure. This creates stress in communities and adds to the burden we already take on as victims of this contamination. We struggle to develop plans with our providers and are left to wonder how our health will be impacted in the short and long term from an exposure we did not choose. It's an incredibly powerless feeling, and we must change this. The costs to exposed communities are significant and devastating. PFAS contamination causes property values to decrease significantly. It impacts businesses' ability to attract and retain employees and customers due to fear of exposure. And it causes chronic illness that drives up medical bills and decreases a person's ability to work. Most exposed communities are also having to pay for bottled water, home filtration systems, PFAS blood tests, and the cost of advocating for more help. Communities did not voluntarily sign up to drink contaminated water or be left to face the devastating consequences of this exposure, but we pay the highest costs. It is critical that action is put in place to hold polluters responsible and make the responsible parties pay for these significant costs. There are huge social and emotional impacts to communities facing PFAS as well. PFAS contamination causes stress, fear, worry, anxiety, depression, feelings of guilt, mistrust, and devastation. It creates a loss of self-worth, happiness, and time with family. Illness associated with PFAS have resulted in people losing their jobs and being unable to work, losing control of their health and their future, all due to something that was not their fault. And some have paid the ultimate price and have lost their life due to illness related to their exposure. Despite the significant impacts this contamination has on many areas of our life, impacted communities struggle to be seen as critical stakeholders. We face a culture within our local, state, and federal agencies that the government knows what is best for us. We constantly have to advocate for a seat at the table to continue to raise our concerns and offer our solutions that work in our best interest. I can't emphasize enough that the people closest to the problem will have the solutions. And our coalition often has to remind those agencies trying to help us that they should not make decisions about us without us. I would like to end by sharing what communities need as we move forward in addressing PFAS contamination. First and foremost, we need PFAS to be strictly regulated to stop the ongoing exposure to communities. Some ways to do this are to classify PFAS as a hazardous substance and to regulate PFAS as a class and not one compound at a time. If this is done, it will also put mechanisms and funding in place to filter and remediate the current contamination. And we must make polluters pay the financial costs of this widespread issue. We also need to improve access to PFAS blood tests that are more affordable. And we need medical monitoring guidance on PFAS issued by the federal health agencies with comprehensive outreach and education to healthcare providers and impacted communities. We must provide the knowledge and tools to allow communities to know what their PFAS blood levels are and to empower them to make changes to reduce their exposure and work with their doctors to prevent chronic illness and devastating health effects. And we must prioritize taking action now on the science we have today. Communities have been exposed for decades, some families for multiple generations. We cannot wait any longer for our government agencies to take real and meaningful action. And lastly, communities must be seen as critical stakeholders and key decision makers in how we address PFAS in our country. When communities are valued and given a seat at the table to develop collaborative and respectful relationships with stakeholders, so much can be accomplished to help those impacted by PFAS. Thank you very much.
All right, thank you all. I think at this point we're going to turn to the online viewing community for questions.
Yes, thank you very much. First, I'd like to remind our online viewers, you can send your questions to grandrounds@cdc.gov, or you can post them on Facebook Live if that's how you're tuning in with us today. Let Let me start with a question from our online viewers from Brenda. I'm going to edit for time. Her concern is that fluoride compounds added to drinking water combined with PFAS may be contributing to the toxicity. So is CDC looking at how these two compounds interact when they come together? PFAS and H2SIF6 may be making secondary compounds and byproducts. Is anyone here addressing this issue?
Sure, I'm happy to start off, and then anyone who wants to add. I think we are all aware of the concerns about exposures to mixtures of chemicals, both mixtures of PFAS, but also combined exposures to PFAS and other chemicals. It's certainly something that it's a concern that we're aware of and that we are working towards answers for. But unfortunately, this is one of the bigger challenges that we face around PFAS in particular right now.
We have questions in the room. If you'll go to the microphone so that our audiences online can hear you.
Hi, thanks very much. I don't know if this is working. I'm Barbara Marston from the Center for Global Health, and I had two questions. One, Ms. Amico, the question you raised about the community challenges, one that was running through my head the whole time all of you were talking, which is why are things considered to be okay until they're proven not to be? And are there any processes for evaluating similar compounds before they're marketed instead of after? And the other one is just if anybody has information about what levels are for exposure internationally or other places outside the US.
I'll just chime in on the whole concept of these chemicals being okay until they're proven not okay. And that's a challenge that, we've been facing under the Federal Toxic Substance Control Act. And, it's unfortunate, and this might be an opportunity to view the need to look at these compounds before they're actually introduced into the market so that we're not playing catch up again in the future.
And then I can add in response to your second question that there is quite a bit of work going on internationally around exposure to PFAS. This is not unique to the United States. And so I think we can probably provide some resources to additional information about what's going on in the international community, maybe as a follow-up.
Yeah, so Steve Redd, the question I have is for Ms. Amico about, it's a personal question about the events that surrounded your decision to become a community leader and really take on this issue. You talked a lot about the importance of that work, but I think for so much of what we need to do to improve public health, community leadership is essential.
Yeah, thank you very much for that. I think my work as a community leader was not one that I ever expected or anticipated, but it took, like I said, something very personal happening to my family to empower me to, first of all, educate myself on what PFAS were, because I had no idea, and then also to start engaging with local, state, and federal health agencies. Initially, it was more local and state that I was working with, and initially we advocated for that blood testing program, and in the beginning I didn't know where all this would take us. I'm shocked 5 years later that we have a health study and we are where we are. It's pretty amazing. But I think what I would say to others is that, it doesn't take a large group of people. It doesn't take, extensive training or education in environmental health. Find that why, find that reason that's so important to you, and work towards making a change, making a difference. And the other thing I've had to tell myself in this work is this is not a sprint. This is a marathon. This is going to be lifelong work for me. And that's something I have come to accept and realize that this isn't something that's ever going away. So I'm not sure if I answered your question or if you were looking for more.
Thanks.
Okay, thanks.
We have a question from Dr. Iskander here. I'm going to lend him my mic.
This has been a very frequent question from many of our audiences, and that is what, if anything, should they do with consumer products they might own, such as nonstick cookware, I think you've already given us some information about the fact that that's maybe not the major source of exposure, but what sort of guidance would any of you give about that issue?
This is Al Ducketman. These compounds are so useful. They are in way more products than most people know about. And they're products that are things we rely on. And to the degree that we can decide that we can either substitute or not have that benefit, then we can potentially improve health. Now, that decision is harder to make at the individual consumer level than it would be to make at a national policy level. But since we are delaying many aspects of national policy, consumers can become educated to find out all the interesting things that these are in. And if we want to spend another minute or two, I could give you a fascinating list of things that you can encounter them in. Maybe you can email me later, and I can send you the PowerPoints from a more detailed lecture, because they're in a surprising number of places, including the Norwegian ski waxers who help the ski wax team. I mean, it just goes on and on. But the choices we make are consequential when it comes to useful products, and that's for sure. And it is the case that the symbol product, the pot, the coated pot, is not the most important source of exposure. The Teflon pot tends to remain intact. There's other sources where there's much bigger surface areas and bigger problems.
I'm Dr. Kyle Horton from Wilmington, North Carolina, and this is a question for my medical colleague. For many of us as clinicians, in the reality of clinical practice is that we're time-starved and crunched, and for those that are tuning in for CME, this may be the first time they've ever even heard of PFAS. How would you recommend a clinician who's busy start the conversation if they're only preliminary aware of this class of chemicals and maybe the extent of contamination in their community even? How do you start the conversation, and what resource would you tell clinicians to go to first for reliable information?
That is such an important question. I'm not fully prepared for it, but I will say this. Someone who's a primary care physician in an affected community needs to write a review article from a community perspective. It would be nice to have maybe a partnership between an epidemiologist but it needs to get done. And I don't think that overall review article exists. There are review articles about specific organs. There's a kidney review article, for example, which I would recommend, but there's no overall review for clinical outcomes that I've seen. Needs to happen. Good websites, for sure, the federal websites, the international websites, they are great sources of information. Anybody has a lot of time, just the front piece of the ATSDR summary, not somebody with a lot of time could read the entire document, but the summary portion can give you some idea about things that are agreed upon that we know these chemicals can do.
And I'll just take this opportunity to restate what Dr. Ducketman just mentioned, that ATSDR's website is a wealth of information, and there is a page specifically targeted for our clinician audience. So anyone listening in on the phone or in the audience, please check that out.
We're rapidly running out of time, but I have a quick question. Maybe we can get that while Dr. Iskander returns to the podium. From Nadia on, I believe, Facebook. It could be our Grand Rounds email box. My question for Dr. Ducketman: can you speak more about the challenges to conducting clinical research on the reproductive effects of these chemicals? What sort of studies can clinicians and scientists do in affected communities?
First, I want to say that there are numerous studies. So it's not that the studies aren't happening. It's that the event is less common, that is to say birth and development, than, for example, the ability to measure cholesterol in all 66,000 of the people who consented to have their blood taken from the C8 Health Project, in which case everybody has that measure, whereas birth and development is a one-off outcome for each of us. So the numbers are smaller, that's to start with. And then secondly, we're measuring things in 2 generations, and then there's lots of issues with consents. So there's lots and lots of challenges, and I've only just scraped the surface there. But that's not to say that it's not happening. The data are coming in.
Thank you all very much. Please, let's have another hand for our speakers. So we will post additional resources on our website, our scientific reading list. We will post a link to Ms. Amico's excellent TED Talk. So please, that's another place you can look for additional scientific resources. Please join us in January for our next new public health grand rounds. Thank you.